And it should be live. We should be live. So to the people who are here, welcome. We'll be starting at the top of the hour. We have a few minutes. So while we're killing time, let's see, what's a good question? What are you going to be for Halloween? Does anybody know yet? Sometimes you get really good answers. I used to be into it, but I'm not now. So I'm also asking if the people can hear us okay.
You want me to say a few things so that I can make sure that they can hear me okay?
Yeah, I just sent them a message on chat to say us. Yes, they can hear us. Yay!
Okay, good.
They can
Okay,
hear both of us. And they're so nice.
That's a start.
I love talking to the audience. They always answer when you need them. Thank you, guys. Anybody have any ideas for Halloween? Probably a unicorn. Oh, that's good. Spider-Man. That's cool too. We used to get dressed up and answer the door. The kids are always surprised when they come to the door and you're dressed up, but we haven't done it in a few years. Nothing fancy though, just regular. Oh, someone else is from northern Wisconsin. Hi, Nancy. I'm from northeast Wisconsin too, and yes, it can greatly impact choices. We have a few more minutes yet before we'll start. And we also have the option of streaming this live on Facebook, so I'm probably going to do that also. In fact, I'll see if I can do that now while we're waiting. And no one else is talking about Halloween, so maybe it's just too early yet to talk about that. Somebody's asking if people down south really celebrate it. I went to Florida last year on Halloween and I did not see too many people dressed up. I don't know. That's a good question.
It's a big thing here in Texas, or at least my experience in Houston. Is there a lot of people who like celebrating and lots of decorations?
I'm from Florida. We celebrate. Well, maybe it was just where you were in Florida last year. So let's see, what time is it? I don't know, I can't see. Oh, we have 1 minute. I'm from Florida. We celebrate in North Carolina now. So yes, I guess the answer to your question is yes. Okay. All right, so it's 2 o'clock. Do you want to get started?
Okay.
All right, then let's begin. Hi, everyone. I'm Heidi Bryan, and I'm the host of this webinar. And I've been in suicide prevention for 20 years. I started a nonprofit organization called Feeling Blue Suicide Prevention Council, which was in Pennsylvania. When I moved to Wisconsin in 2011, I gave the nonprofit status to another organization I co-founded, which was at the time called the Pennsylvania Older Adult Suicide Prevention Coalition, but has now since changed its name to Prevent Suicide PA. I've been consulting and working independently in Wisconsin, and one of the things I've been focusing on is helping families after a suicide attempt. And in fact, I just created a course, an online course to help families with that. And the subject of shame and stigma comes up a lot, and especially shame. So that's why I wanted this webinar. And I happened to find out about a webinar on shame by Cynthia Mulder, and I signed up for it, and I was just blown away. And I thought, this is perfect. I have to get her for a webinar. So I'm so happy. I contacted her, and she agreed to do this. So as Director of Education and Training at the Menninger Clinic, a private psychiatric hospital in Houston, Texas, Ms. Mulder is responsible for overseeing the varied training programs for trainees, including the Postgraduate Social Work Fellowship and staff at the Menninger Clinic. She serves as a supervisor to postgraduate fellowship candidates and entry-level social workers working towards advanced licensure. She is also a senior social worker who provides individual therapy, psychosocial assessments, family therapy, and aftercare planning. Ms. Mulder is an instructor for Menninger's Family Education Day and facilitates the Daring Way, a shame resilience curriculum for which she is a consultant and trainer. After earning a bachelor's degree from Middlebury College in Middlebury, Vermont, she earned a master's degree from Smith College of Social Work in Northampton, Massachusetts. And she is also currently a candidate in analytic training at the Center of Psychoanalytic Studies in Houston and is an assistant professor at Baylor College of Medicine. So without further ado, I will give you Cynthia Mulder.
Thank you so much, Heidi. It's really, I'm so happy to host this, and I hope that what I have to share is helpful to everybody listening. Over the past 8 years, I've been exploring and working with clients or patients, families, and clinicians on this concept of shame. And, you know, as a clinician, I was aware of it in my training, but I don't really think that it was fully explicitly discussed or explored as how it could be impactful in psychotherapy. And so over the last 8 years, I've been running a group on the professionals unit called Shame Resilience. And so in this group, I've been exploring the work and working with Brene Brown. And so I hope to share today some of what I've learned through the process. And my hope is that as we speak about the role of shame in our lives, whether it's patients, family members, or our colleagues, that we can understand how shame can be a contributor to suicidal despair, or also to, in the wake of a suicide attempt or death by suicide, the shame or stigma that comes from having to work through the grief and loss for those remaining. And so one thing that's important for me to share is that I am a senior faculty at the Daring Way, which is the educational arm at Brene Brown's organization. But I only receive any financial support when I'm actually being a trainer for the Daring Way. And so what I hope to do, and actually when I'm running the group and facilitating our family education day, I always ask people, how many people have ever had a conversation about shame? And the overwhelming, maybe 90% of the time, people say that they've never had a conversation about shame. And I think this is why I'm so passionate about it, is because what I've learned from the group participants is how powerful it has been to understand the link between shame and their struggles. The ability to language it, to give voice to it, and then help people develop more resilience or develop a resilient spirit. And so I put forth this argument that shame is ever present in our work and in our lives, but it's very hard to discern and very difficult to talk about. And so we also say you can't be shame-proof, but you can become shame resilient, meaning you learn to notice when we're in it, how to move through it constructively and not make the situation worse for ourselves. A tall order. And so what I hope to accomplish in this webinar are these learning objectives. We'll spend some time on thinking about the difference between the emotions of self-conscious affect and what may trigger somebody's shame. Talk a little bit about the link between shame and psychopathology, or what brings somebody into treatment. And then the importance of both the presence of shame, but being able to speak about it with a trusted person. And so both how empathy and self-compassion are essential to building resilience to shame. And the more that we can speak about shame with trusted individuals, then we're going to become more resilient and will actually improve our recovery from all of those things that individuals and families struggle with. And so I'll do a little brief recap of the literature, which I think is interesting because for those people who are treating individuals who are suicidal, one of the things is even knowing about how shame shows up in the literature around psychotherapy. And so when I was beginning to do some research and prepare for a presentation a couple of years ago, I thought it was fascinating that in 1872, Charles Darwin was actually describing shame as he was categorizing animals and species. And then it was 1895, so well over 100 years ago, Sigmund Freud began to think about and write about shame. Although all of the research shows that Freud sort of privileged guilt over shame. And this quote here, Carl Jung referred to shame as the swampland of the soul. And when I share that with patients and families, there are lots of heads nodding because that sort of captures sort of the difficulty of grappling with the emotion of shame. Moving from Freud to Erik Erikson, one of the things that we learned about is where shame begins to show up in development. And so he was putting forth that between 18 months and 3 years, which essentially is sort of toddlerhood, is where the concept of the emotion of shame begins to develop. And so in here on this slide, you look at the difference between autonomy versus shame and doubt. And so if we think about the know of toddlerhood, the ability to walk and explore the world, as a caregiver, oftentimes that's when we're first beginning to see babies and toddlers begin to grapple that. And this is the importance of the caregiver relationship in terms of how they manage and how we manage some of those challenges. And as a child is sort of differentiating and finding their way in the world, how do we do this with what I'll speak to later, coming from as healthy a way of responding to their autonomy. But what we see is that shame is getting developed in people from a very early age. And one of the most pivotal writers about shame was the psychoanalyst Helen Block Lewis, who in 1971 wrote Shame and Guilt and Neuroses. And what she did that has really stood the test of time is differentiate between shame and guilt. And what this slide is looking at is how shame hinges on the self, the feeling that I am bad, I'm flawed, I'm inadequate, whereas guilt focuses on a triggering behavior, something that a person has done, that they did something bad, they made a mistake. And so in the emotions of self-conscious affect, shame is much more painful, long-lasting than guilt, and guilt is attributed to being more motivating. But she was instrumental in thinking about the difference between these two. And why this is important is because they often get used interchangeably, and they have very different ways of being experienced, and also the link to psychopathology. But so 1971, sort of the idea of shame comes back into the literature. And then when we think about Heinz Kohut in his self-psychology, he really begins to think about the concepts of empathy, mirroring, and working on the way that somebody may have a damaged inner sense of self. And he also begins to theorize around a lack of parental empathy during development may lead the patient or client unable to regulate their sense of self, their self-esteem. And then we begin to see this dynamic of either overestimating one's capacity or a sense of inferiority. And that sense of inferiority, again, links to shame. And I just loved this quote, which is, "The language of shame, the ultimate recognition of a failure of all-encompassing magnitude." And that recognition of a failure could be a very small event or issue, but that feeling of a failure of all-encompassing magnitude is, in a way, captures that emotional state. We keep moving forward in time. In the 1980s, there was a movement really fueled by people in addiction work and recovery around thinking about healthy shame, toxic shame, carried shame. And this is the work of John Bradshaw and Pia Mellody. But they were really, again, looking about different attributes of shame. And then as we move into the late 90s, June Tagney and her team began to again, tease apart distinct emotions of shame, embarrassment, and guilt. And again, going back to really think about the intensity of shame, the physiological changes that go with shame, whether it's blushing, increased heart rate, the sense of isolation, the desire to hide, the desire to not admit anything that had been done, any mistake made, and a real sense of scrutinizing their own thoughts was really coming out in the literature at that time. And so this slide, which is really brings us up to some of the work of Brene Brown. And much of my work I'm going to talk about is actually through the work that I've done with Brene and her research. But if there's a slide that is sort of a takeaway slide, this is it. Because the difference between embarrassment, humiliation, guilt, and shame is essential in helping people understand what's happening within themselves. And in the group that I run, this is the beginning of every single group. And by the end of it, the patients are able to actually delineate these terms themselves. And I think of that as a real win, that if people in my group understand the difference between shame, guilt, humiliation, and embarrassment, they're on their way to being their own detective about where shame shows up in their life. And if we think about intensity, frequency, and duration, embarrassment is the least intense. It's fleeting. It becomes funny. And what's essential is that we know that somebody else in this moment has had a similar experience. And so that makes it bearable. We've all probably had food stuck to our teeth. We've all probably mispronounced someone's name. We can laugh about it, maybe not in the moment. But and then we go to humiliation. And humiliation, what distinguishes it from shame is that there's a sense of that we don't deserve whatever has happened. And if we don't deserve it, it evokes anger, and therefore we talk about it. So that you'll hear, "You're not going to believe what that person just did." Or "I can't believe this just happened to me." It's still painful, but we believe we don't deserve it. And so then it's very easy for us to talk about. As I said earlier, guilt is a motivating emotion. And we can correct mistake that we made or a behavior that we did wrong. We make amends and we apologize. And so in that amends and in that the motivation, we try not to repeat the same mistake or the same behavior. With shame, we feel we deserve whatever is happening to us. We believe we are bad, flawed, inadequate, unworthy. And so because it's sort of not news, we stay silent. And in that silence, it leads to a lot of self-destructive behaviors, the things that bring people into treatment. But it's there when we think about, again, intensity, frequency, duration, the most painful, the most long-lasting, the most intense will be shame. And this is, again, a key learning from this presentation. And so, as I said, shame is not motivating. And this really comes into the research, as you can see here, about Brene Brown and also Tagney and Deering, who continue to do a lot of research on shame. It used to be that people believed that they could shame you into change. And so on this slide, here's a little image of somebody in a dunce cap. And so the thought was, if I put a dunce cap on you, that would motivate you to become a better student. And the research shows that this is not actually in truth. This is where Brene would differ from Bradshaw and Melody, saying that there's no such thing as healthy shame. The guilt is the motivating emotion. And also the research shows that by the 5th grade, you can identify if a child is shame-prone or guilt-prone. But shame is not present at birth. So if we go back to one of those original slides, Eric Erickson and others are putting it in around 18 months to 3 years. Others put it around 4 to 5 years, that it is a process that we actually learn through our relationships. But it is not present at birth. And so when we think about to understand shame, the experience tend to be very intense and overpowering. As we've said, it has this sort of sense of being bad, worthless, unlovable. There's a physical sensation associated, often it's a sense of being powerless, or maybe you're shrinking, getting small, feeling exposed, wanting to hide or disappear. And we also know that shame doesn't like any words wrapped around it. So it likes secrecy, silence, and judgment. And it becomes avoided, or it gets used with terms where people might be saying that they're embarrassed when they're actually really talking about shame. But shame is really linked to a desire to hide. The feelings stay hidden. It's very hard to speak about them. And I think this is important because shame is processed in the body and in the sort of limbic system, the same place that trauma is processed. Our bodies actually respond to shame before our conscious mind, our prefrontal cortex checks in. So we're reacting to shame in the fight, flight, freeze. And it takes time for us to get our prefrontal cortex online to begin to think about it. So this is why understanding one's relationship and triggers to shame become really important in our efforts of slowing down any behaviors. Oops. So if we think about when we learn about shame, we're learning about shame in our childhoods, through caregivers, through teachers, religious leaders. It begins as a two-person experience, meaning I have to learn about shame with another person. But then it becomes a one-person experience, meaning nobody has to say anything to me that's shaming, but I have already internalized a shame self-script where I can sort of be off to the races all on my own. So it starts as a two-person experience, it's a relational construct, and then we can be in our own shame storm without anybody actually having said anything to us. We also, shame is powerfully influenced by culture, and so the desire to fit in and be liked is quite strong, and so that we can sort of modify who we are by sort of who you should be, how you should be, and what you should be. And this gets communicated through the media, social media, all the time. What we know is that shame unravels our connection to other people. And the more that and ourselves, and the more that we're disconnected, the more we sort of lose our own sense of authenticity. And I love this quote from Brene, which says, "Shame corrodes the part of us that thinks that we can change." And so when we think about trying to engage people in psychotherapy or in recovery or helping them, shame is not motivating. In fact, it is more linked to the ways that it sort of unravels our capacity and our belief in ourselves. And this book is called Shame in the Therapy Hour by Rhonda Deering and June Tagney, is a wonderful edited book with different clinicians writing about how they understand shame from multiple perspectives. And interesting, what was repeated through all the articles was that the word shame is actually avoided in everyday language. You probably will hear more about people being embarrassed. It's inherently linked to this desire to hide or conceal, and therefore the effort is to try to even avoid the feelings. And that for many, therapists may inadvertently avoid shame-related issues with clients. And so I think our goal is to how do we listen for shame in a client or patient? How do we have curiosity and how do we have empathy? Especially with those people who are struggling with suicide, that to encourage people to bring that forward with empathy and to be received with empathy and validation is really important. And our ability as therapists and helping professionals to understand that flaws, setbacks are normal and don't warrant the sort of global feeling of worthlessness and shame that a client may inflict on themselves. And so, you know, what Deering and Tagney were talking about is that clients seek therapy for shame-related issues, but then can actually struggle to talk about them. But the more that we verbalize these shame-inducing events and all the associated feelings can reduce the pain of it. And what they said that was so powerful to me was that and what I've highlighted here is that the degree that the therapist understand the difference between shame, guilt, embarrassment, and humiliation, but really shame, guilt, and embarrassment, the more that the therapist helping professional understands the differences among them, the more that they're going to be able to help somebody heal from them. So that slide that I said, this was a key learning, that's in fact why I'm saying that, is because the more that we become aware of the distinctions between them, we're listening for it, we're begin to provide some education for our clients and family members, we're going to help decrease the power of shame and have more healing. And so I want to talk a little bit about the correlation to psychopathology, because there is a lot of research that shows how shame is linked to disorders of the self. And so I'm going to share a couple of references and writers. This is by no means exhaustive, and I've probably left a few people out. That was not my intent. But you know, we think about, on this first bullet point, shame is intimately concerned with the disorders of the self. All states of clinical personality fragility, identity diffusion, social phobia, all of the things that are sort of behind affective phenomena, whether it's depression, anxiety. And then Lansky also looked at the role of shame with suicide. And I think the ability there may be a lot of discussion around suicidal despair and our ability to know that shame is part of that suicidal predicament. And the clinician who understands those properties of shame will also probably be able to understand the interpersonal world, both in the family and in treatment, the self-hatred, the self-loathing that fuels both despair and, for many families, wondering, what did I miss? And again, Tagney and her team looked at shame proneness and ways that can impact self-functioning, feelings of hopelessness. And she also began to make the link that even the experience of psychological symptoms, to have those symptoms, can exacerbate shame. And then Brene Brown, she made it very clear around shame proneness strongly being linked with depression, addiction, eating disorders, self-harm, bullying, aggression, violence, and suicide, all of the things that bring somebody in to seek help are strongly correlated with shame. But again, oftentimes that's not explicitly discussed. And again, Deering and Tagney in a 2011 article, they were noticing shame proneness being linked with problems of hostility, anger, low self-esteem, suicidal ideation, depression, eating disorders, PTSD, substance use, and substance abuse. So it's highly, highly correlated. And then again, one of the researchers, Morrison, noted how shame can be an instigator or a response. I found this both true and fascinating, that shame and low self-esteem can play a part leading to addiction or dependency because you're trying to dilute the painful feelings, and then the addiction creates further shame. In a similar way, maybe there's shame around body image that leads to an eating disorder as a means of coping, and then having an eating disorder may evoke shame at the ways that the disordered eating has shown up in their life, or the designation of being sick. And we could be interchanging different diagnoses into these quotes, and that oftentimes shame experiences from childhood and adolescence can function as traumatic memories. And so those traumatic memories can become sort of central to how somebody has a sense of themselves, and then can develop future psychopathology. And this next one was, again, looking at the difference between shame versus guilt, because these two terms get interchanged quite frequently, but again, are very different. And they noted maladaptive guilt as being fused with shame. And so I oftentimes think about the guilt-shame superhighway, which is you may start off feeling guilty about something, but then you've dropped into feeling shame about something. You know, if somebody's apologizing once, making amends, and moving on, we would say that's guilt. But if there's apologizing, overly apologizing, constantly apologizing, in essence, apologizing for their own being or self-concept, then we've moved into shame. And again, Cynthia and her group was also looking at shame proneness being linked to a lot of the issues that bring people into treatment, and those issues that also can lead somebody into suicidal despair. And so that brings me to Tom Joyner's theory, his interpersonal theory of suicide. And this looks at why individuals engage in suicidal behavior. And also this diagram sort of shows the people who are at the highest risk. He writes about this in his book, Why People Die by Suicide. But if we look at these components, the thwarted belongingness, that sense that I'm alone, I don't have any connection, or perceived burdensomeness, I'm a burden. Those two are sort of bringing forth the concept of shame in those two sort of concepts of belongingness and burdensomeness. And then when you add his third construct, which is the capability to make a suicide attempt, that the quote is, "I'm not afraid to die," you can see how the intersection of these put somebody at very, very high risk. And so I would suggest that those two, the thwarted belongingness and the perceived burdensomeness, are also then make a direct link back to the concept of shame and the feeling of shame. And so if we're to think about how to develop resilience to shame, one of the things that Brene Brown has done is she's created a 12-session psychoeducation curriculum. And she writes about this extensively in her book. I thought it was just me, but it isn't. She then wrote The Gifts of Imperfection, Daring Greatly, and now Rising Strong, then Braving the Wilderness. She has many books, but if we think about back in 2009, she created a 12-session psychoeducation curriculum that was really drawing on the concepts of the physiology of shame, then learning about how we learn about shame from our families of origin, and then influence how we talk to ourselves today. Again, think about the role of empathy and self-compassion. In this curriculum, there's also some work on getting clear about the values that should be guiding us in our lives, understanding what shame triggers are, and ultimately being able to speak about shame. It is so important for an emotion that wants to be hidden to actually give voice to it. This curriculum also emphasizes the importance of the therapist understanding their own role and their own relationship to shame in order to be able to facilitate this. Because if you don't understand how shame is showing up in your life, then you can unwittingly shame other people. And all of Brené's research have evolved and are encompassed in this program called The Daring Way. And you can go to the Daring Way website and it'll give you lots of information. And there are clinicians that are trained in her work. You don't have to be certified in her work to increase your awareness, but she's got TED Talks out there. Even by attending this webinar today, you are working towards increasing your own awareness to where shame may be showing up in your life. And so through all her research, she came up with a definition of shame. And she uses grounded theory research, and after more than 13,000 interviews, she came up with this definition that shame is the intensely painful feeling or experience of believing that we are flawed and therefore unworthy of love and belonging. And so, again, this painful feeling and this belief that we're flawed and therefore unworthy is something that we learn through another person to begin with, and then we can do by ourselves all on our own. We oftentimes say you can't be shame-proof. I think I said that at the very beginning. And the 1, 2, 3s of shame is we all have it. We don't want to talk about it, and the more that we don't talk about it, the worse it gets. And yet to talk about it is sort of a paradoxical because it's so painful to talk about. So if we think about what triggers shame, and that's an important component, each person has their unique triggers, and what triggers me may evoke guilt in another person, may be humiliating or embarrassing for another person. Our capacity to know what triggers our own shame is based on our lived experience of the world. And so these 3 big concepts of scarcity, comparison, and unwanted identities are ways to think about that might trigger shame. So the concept of scarcity, not being enough, not blank enough. You fill in the blank. Are you not smart enough? Are you not stable enough? Are you not thin enough? Are you not strong enough? However you fill in the blank. And then there's sort of a secondary script of this question that might be nagging you, feeling like, who do you think you are? Who do you think that you could be doing this thing? Because you're not smart enough, you're not educated enough, you are not wealthy enough. Whatever the not enough is a trigger for shame, this concept of scarcity. And then another trigger is comparison. And comparison is so dangerous because we often compare ourselves to other people and then feel that we don't measure up. We take our eyes off what we might be doing, look over and see what somebody else is doing, and then feel that we're not doing as good a job. And so comparison is oftentimes showing up very early in life. And the more that we can note where comparison is and try to quiet that down becomes really important. And then another concept is unwanted identities. And so this goes back to an idea of we all want to be perceived in sort of positive ways. But if we have the sense that we're getting viewed in a negative way, so what I've put on the slide here is that if you're unstable, if you're weak, if you're addicted, fat, lazy, stupid, if you have the sense that somebody's perceiving you that way, that can be an elicitor of shame. Whether or not it's true, it's that the perception will start driving shame. And that desire to not be viewed in a negative light gets quite activated. And then as soon as the shame is evoked, we may try to control perception. And so these shame triggers kind of dictate how we think, feel, and act every single day unless we become really clear about them. And when I'm running group, there are lots of ways that people can very, very quickly say how they don't want to be perceived based on the fact that they've had to come into a psychiatric hospital or have a psychiatric diagnosis. And so this idea that that's sort of ever present in different areas of our lives, whether it's a psychiatric diagnosis or parenting or physical appearance, education, there are lots of ways that we are vulnerable. Wherever we're feeling vulnerable, we will probably be vulnerable to shame. And so just again, to sort of, the physiology of shame is that it hits us viscerally. And so my little ginger person here is based on where does it show up in the body? There are lots of physiological symptoms, heart racing, time slowing down. Sometimes people talk about tingling sensations, muscle tension, nausea, anxiety, flushing. And so even the word shame can invoke the feelings of shame. And if you thought about a shaming moment in your life, the physiology of that would begin to happen in your body. And so those sensations, even in thinking about a time when you have felt ashamed, will begin to come back. And so these symptoms and sensations are incredibly important, again, because you respond to shame before your prefrontal cortex comes online to be able to say, oh, I wonder if I'm in some shame. So the quickness at which this happens is very fast. And this slide looks at we do this as a group process or a group project, and we get people to try to think about where shame shows up in their body. So here are two examples of sort of ginger people. Again, you can see the blush on the left-hand side, the face, the confusion in the head, the sort of everything that's happening in your heart or in your gut, feeling weighed down, feeling like you can't speak. And then on the other side, again, feeling like there's this weight on you, something in the gut, tears, feeling that, and yet holding a mask that might be showing everything's fine, but underneath this is what I'm really feeling. And that's one of the powers of shame, is that there are very few signs that you're actually in it unless you are blushing or sort of sweating profusely. The rest of them are going to be sort of an internal process, which leaves us even more alone and isolated, because you might not be able to see that I'm in shame. And so when we think about feeling isolated, disconnected, and in fear, which is oftentimes what's happening in shame, that little visual of the face, it may look fine on the outside, but inside there's a whole lot of distress going on. So when that distress is happening, again, this is based on the work of Brene Brown, there are sort of predictable ways we respond. And this is discussed extensively in Daring Greatly, her book from 2012. And one of them is with numbing. We don't like the feeling of shame, and so we numb with food, with alcohol, with work, with internet, binge watching, Netflix, shopping. There are lots of ways that we numb to try to protect ourselves from feeling shame. There's also a concept called foreboding joy, which is, again, we're going to stop enjoying a moment to consider a catastrophe. And how this shows up for me in treating patients is I often will say, when somebody says to me, I feel better today, I'm having a good day, the next sentence out of their mouth is, I know this won't last, or I worry that it won't last. And so in that moment, they've left the joy or the pleasant experience of feeling better to dress rehearse tragedy, catastrophe. This isn't going to last. I think we also do this sort of naturally when we're on vacation. We might be enjoying vacation, and then at some point our minds go back to the fact that we have to go back to work, and we've sort of lost that sort of vacation glow to begin to dress rehearse stress and sadness. And that's what we call foreboding joy. And then another big piece of armor that we try to protect or ward off shame is through perfectionism. And so Brene says that perfectionism is a 20-ton shield with an effort of protecting ourselves from experiencing pain, hurt, and vulnerability. If I do it perfectly, I'll avoid feeling shame. So sometimes people will say to me, I don't really know what shame is, but boy, am I a big perfectionist. And so then what we talk about is shame is the birthplace of perfectionism. And to then embrace healthy striving or striving for excellence would be different from trying to be in a process addiction of perfectionism. Because perfectionism is, we consider that a process. You get addicted to the process of trying to make something more perfect, more perfect, more perfect. Then there's also, so we're in shame, we try to protect ourselves from shame, and then we have some ways that we react and respond to shame in very patterned ways. And the first one is what we call moving against. And this is the shame aggression cycle. So that if you're in shame, you just react in that fight dynamic of you might blame, you might become passive aggressive, you might actually lash out at people. But then there's the sort of external way that people may move against. Then there's also an internal way. They might use self-harm. They might use suicide. There may be a high level of self-loathing, the attack on the self that is a moving against. Then there's the strategy of trying to, or reacting to shame, which is we call moving away, which is flight. Flee, avoid, disengage, disappear. Even in the presence of other people, people may just disengage or avoid. And then there's a dynamic which is moving towards. You're in shame, but you move towards people-pleasing, appeasing, winning people over. But it's coming from a place of shame. It's very different if you genuinely want to do something nice for another person. That's not reacting to shame. That's thoughtful, mindful, intentional. I genuinely want to do something nice for somebody. But if I'm feeling insecure, inadequate, and so I decide that today's the day I'm going to bring donuts to the unit because I really want those clinicians to like me, that's a moving toward. That's more of that people pleasing. And so oftentimes there's a way of understanding if they've used these shields, ultimately, which are sort of acting out or shutting down, there may be a way to understand where shame is showing up by looking at these shields that they use. And it's sort of a back door of understanding shame. Somebody might say, oh yeah, I'm a total people pleaser. I say yes all the time rather than saying no. And we might then be able to work at understanding what that's about, what shame, when shame is activated. Same thing with blame or moving against. But again, that's the fight, flight, freeze dynamic. Very quick, very hard to slow down. And so this sort of recaps a little bit of it, which is how shame is triggered, activates the limbic system, the prefrontal cortex is hijacked, so we're just reacting. We use shields, moving away toward and against, and then however we react, it leads to more shame and further disconnection. And so this is a great image that, sort of looks at how shame develops, which is on the left-hand side, judgment, secrecy, and silence is a breeding ground for shame. But if you douse it with some empathy, then it's difficult for shame to continue to grow. But the only way to douse it with empathy is we also have to give voice to it. So what we talk about is empathy is the antidote to shame. And so the attributes of empathy, which is based on the work of Teresa Wiseman, is perspective taking the other person's perspective, staying out of judgment, recognizing their emotions, communicating our understanding of that person's feelings. And then Brene adds mindfulness to the attributes of empathy, that we're mindfully trying to empathize with another person when we are also able to devote some time to do that. And so empathy is really the ability to perceive a situation from another person's perspective, to see, hear, and feel the unique world of that person, not our own, but theirs. And that means that we can't start judging them, because then we're no longer in a place of being curious about their experience. I wanted to show you a little video, but unfortunately we couldn't get it to work. So if you Google search YouTube, on YouTube, Brene Brown empathy and RSA short, it will give you a nice little video clip where she's talking about the difference between empathy and sympathy. And I encourage you to look at that. You know, thinking also about empathy is also validation. And how do we validate the feelings that the other person is bringing to us? How do we validate the feelings, but it doesn't mean we approve of the behaviors. So I might validate the suicidal despair that the other person is bringing me, and try to hold open that there are other options rather than making a suicide attempt. So being able to communicate that I hear that they're mad, scared, and whatever else that they're feeling. And I try to work with patients, I'm thinking about the concept of both and, which is they're both scared, I hear that they're both upset, and could we find a different solution, versus getting into right, wrong, black and white thinking. And invalidation is essentially telling the person not to feel the way that they're feeling, which oftentimes when the subject of suicide and suicidal despair comes up, because of how emotional it is and how scary it is, oftentimes, you know, people can unwittingly become invalidating. And clients, patients, people can then invalidate themselves. But invalidating often looks like I shouldn't feel this way, don't be so sensitive. It's not about fixing, it's really about trying to hear. And so that's why places where their support groups are all built on trying to validate the feelings that people have. And so empathy is essential, the ability to share a story and be met with empathy. But there's also another key component, which is self-compassion. And people with high levels of shame have very low levels of self-compassion. They have poor self-kindness. They don't think of the struggles being unique to other people or being experienced by other people. And so when we think about self-compassion, we think about self-kindness, common humanity, and mindfulness. The flip side is self-judgment, isolation, and over-identification. And so the ability to be kind to oneself. Do they talk to themselves like somebody that they care about? That's the beginning of self-kindness. And this website, www.self-compassion.org, has an actual self-compassion quiz that you can take. And I really encourage people to take it and then practice self-compassion, and 6 months later, take it again. But I tell all of my patients at the beginning, your score is probably going to be pretty low, which might trigger some shame. It's understandable that you would have a low self-compassion score because you have such high shame. And what we want to do is begin to shift the balance of the scale towards more self-kindness. And that's very hard to do, but possible. And so when we think about developing resilience to shame, we have to recognize when we're in it, what triggered it, pause and not make the situation worse, really try to step back and get some kind of perspective, because shame wants us to believe that we're the only person that fill in the blank. We have to begin to challenge that. And we have to identify people we can trust to hear our shame and our stories, practice self-compassion, clarify what really matters to us. And this is where the work of ACT, acceptance and commitment therapy, can be extremely helpful. But the more that we can be clear about our values, it helps us to connect to ourselves. They could also be inspirational or aspirational values. Maybe we've been so depressed, we haven't been as engaged as we wanted to, or addiction has thrown us out of alignment with our values. But if we can get clear on the values, that's going to help in developing resilience to shame. As I've said, to reach out and speak about it, and the more that we could speak about it, it allows us to stay connected and understand we're not alone. Very hard to do, but possible. And I love this quote: if I share my shame story, will they be another piece of flying debris in the storm, or are they like the sturdy tree firmly planted on the ground? We all need to have people who are sturdy on the ground, that can bear the weight of the shame story, not respond with fear or fixing, but simply try to be that sturdy person. That could be a therapist, it could be a member of the clergy, a friend, a family member, but we really need that in our lives. And I need that in my life because I'm not immune to developing shame as well. So when you're listening for shame, I think that's one of the important things, is the more that we can try to suss it out and hear it, we can help others. And so what descriptions does the person use? Do they talk about self-hatred? Do they talk about feeling inept, inferior? Do they use the word embarrassed? Do they feel worthless or inadequate? Are there words that they're using that you might be able to then say, I wonder if what we're talking about is that there's some real shame present, that you really feel flawed or inadequate. Pay really close attention to where comparison and scarcity, that not blank enough, is showing up. Or can you facilitate a discussion about how they don't feel enough? And then again, we might begin to challenge that. There may be examples where they've used shields or have really been armored up or protected. And then this idea of how do we reality check the shame messages of I'm the only one that, I'm bad, and really try to get a broader perspective. Again, that's where support groups are really helpful, because they're not the only one who struggled with depression. They're not the only one who struggled with bipolar disorder, addiction, Overeaters Anonymous. Those support groups oftentimes are a way of in vivo developing resilience to shame. And the importance of empathy and validation of the feelings. There's nothing worse than having somebody say, I feel so ashamed, and then another person trying to talk them out of that they shouldn't feel ashamed. That usually doesn't go well. So key lessons: we can't be shame-proof but resilient. Hopefully we can articulate the difference between shame, guilt, humiliation, and embarrassment. We can help ourselves, our patients, our families identify where they are vulnerable to shame, identify trusted people to speak about it, and then to really develop a self-compassion practice and a gratitude practice to develop resilience. And again, a lot of this is covered in the book Daring Greatly. And I want to leave you with this image. So the image on the left was sort of the grim reaper of shame. And then the image on the right is what we call a resilient spirit. And so the image on the right is saying that they've been able to connect their head and their heart. They've been able to break the bonds of shame, that they still have some wounds that have some bandages on them, but they have a sense of their eyes are open, they're looking at the world, they're finding a way to be connected authentically to themselves and what matters through their own voice. They have a little scarf that says that they can tackle the world in the ways that living life on life's terms, but they're able to see and be connected. And I thought that was a beautiful way of sort of thinking about having a resilient spirit and having that awareness of shame at the same time. So I want to thank you for participating and I guess answer whatever questions you have. And hopefully that was useful and helpful.
Thank you, Cynthia. I thought it was great, and my head is just going, and I can't even formulate the questions that I have. But the only question we have so far is about a copy of the slides. Will they be available? And
yep, I'd be happy to make them available. I just need to take out the pictures, and I can. You can send the slides, I guess, with a survey or whatever.
Okay. Okay. So should they contact me or you?
I'll send them to you, and then you can
Okay.
send them out with whoever participated.
Okay, that's great. And the other thing I want to mention while I'm talking about that is that I can also send you the bibliography which you provided. And if anybody wants a certificate of attendance, you can also ask me for that, and I'll provide that as well. Somebody said that this has been very eye-opening. Thank you so much. And another person said, awesome for me personally and professionally. And I agree. I'm in therapy. I'm an attempt survivor and a loss survivor, and I have PTSD and other things. And recovering alcoholics, a lot of shame. And my therapist would say, once said to me, and he wasn't even really thinking, it was just kind of came out like, oh, you're so shame-based, I can't even say that. I can't even say what I'm thinking. And I looked at him and I didn't know what that meant. And it just stayed with me for so long. And it wasn't until recently that I started to understand what he meant, and that I was so shame-based. I am so shame-based. And it's almost like an automatic thought kind of thing. It just kicks in.
Right. It would take a lot of work. I mean, what requires it is it takes a lot of work to say, oh, there it's again. There's that shame self-talk of being inadequate, not enough, what's wrong with me? And to begin to challenge that and what I say is, let's turn the volume down on the shame self-talk. Let's just turn the volume down, because oftentimes it's super loud and it's not accurate, right? And it doesn't actually help us change things about. I mean, it's hard to do this work, but very, very possible. But if you don't know that shame is actually operating below the surface, you have to know how it's operating in your life in order to be able to say, you know what, I'm going to turn the volume down. I'm going to take my foot off the accelerator of shame and get over into a different lane that says more compassion, more kindness. I'm still held accountable, but I don't have to beat myself up relentlessly, because I would never do that to another person. Most people are more relentless, critical, and ruthless on themselves than they would ever be to another person. And so the ability to say, let me practice some self-kindness, because I would never talk to another human being like I talk to myself.
Yeah, I know. Sorry, I just got everybody's just saying how much they loved it. Very informative on a personal and professional level. Thank you very much, from a recovering perfectionist, which I love. And Bill Hawley says, pray for self and forgive self.
Yes.
And somebody said that as a CSP, which I'm thinking is a certified, oh no, that's different. As a new CSP professional, this really hit on aspects for probably all of our clients, and very helpful. And I agree. And I think this just isn't discussed enough. Like, as I said, I've talked to families and other attempt survivors, and we know shame is there. Shame is a huge part of it, but I feel like no one ever talks about, or if they do, they don't tell us how to fix it. What do we do? So that's why I really was so grateful that you accepted my invitation to provide this webinar, because you and Brene Brown are really the only ones talking about how we can deal with it. So.
Well, if you go to the website, you'll find tons of the website has a search engine, and it has a little thing you can type in your zip code, and you can find people who are trained in this work all around the country and the world. And I think what you're saying is this attempt survivor, a suicide attempt survivor, and also if you've had a family member die by suicide, there's both shame in the components of making the attempt, and then there's shame in the after effects of having made an attempt, or being a survivor of having a family member who has died by suicide or made an attempt. So it's on both sides of it that is so powerful. And as you're saying, and others are saying, it's very hard to find a way to talk about it, but talking about it is essential. Yes.
Jennifer said, it's interesting that shame can be linked to the three main dysfunctional core beliefs theorized to exist for suicidal individuals. I'm worthless, I'm unlovable, and I'm helpless.
Right.
Which I agree. I just, like I said, my head's like ready to explode, because I'm like, there's so many thoughts going on, but, and I know we're reaching the end of the hour. One person just said, I'm trying to practice self-compassion and self-care. I encourage others to watch the Brene Brown short on empathy versus sympathy. Thank you. And there's also, I guess, a commercial on that supports talking kindly to herself. So it's on YouTube, and she put it in the chat. So, great. Again, my email is heidi@heidibryan.com. I'll type it in again. You can email me for the slides, for a certificate, bibliography, whatever. And I guess that's it. Thank you so much. And one more thing I wanted to say is when my brother killed himself, I felt like there was this red flag that was now flying over me. It said dysfunctional family here, like it, and it was amazing. It was a shame. I felt so ashamed that he killed himself. And now, I realize why,
Right.
why? It had nothing to do with me. It had nothing to do, it had nothing about that. It was, it was his pain. It was about him and his pain. So,
Right.
yeah. So, okay. Well, thank you again very much. And thank you all of you who attended. And I appreciate that. And I look forward to hearing from you. Take care.
Bye-bye.
Bye-bye.